And here we are. All right, so again, more than behavior, supporting sexual needs with compassion. Our guest speaker is Stephanie Ross. She's a psychogeriatric resource consultant at Ontario Shores Centre for Mental Health Sciences, serving the central eastern region of Ontario, primarily Durham region. She began her career at Ontario Shores in the geriatric dementia unit as a patient care attendant, then returned as a registered nurse after earning her Bachelor's of Science from Trent University. Over an 18-year tenure, she's contributed to initiatives such as choking risk improvements, stepped into the patient care facilitator role during the COVID-19 pandemic. Stephanie facilitates staff support in long-term care homes, particularly those with older adults experiencing dementia and complex mental health issues. As a psychogeriatric resource consultant, she supports education and capacity building in long-term care through programs like Dementiability, BSO Foundations, PIECES, Gentle Persuasive Approaches, or GPA for short, and many of which are the core competencies for the Behavioral Supports Ontario or BSO program. Her educational outreach promotes best practices, de-escalation, validation, therapeutic activity adaptation, and non-pharmacological strategies for responsive behaviors in dementia care. She connects evidence-informed dementia practices directly to frontline staff, enhancing care quality and caregiver competence. So just a reminder, we will have, if we have time, we will answer questions at the very end of the presentation. Please do pop them into the chat, but I'm going to stop sharing on my end. Stephanie, you are good to take it away.
Perfect. Thank you so much. Just gonna. Sarah, should I minimize all of the floating panels? Presume is that would be what's recommended during the presentation?
I don't see any of them popping up on your screen, so I think
Perfect.
you're okay to go.
Lovely. Awesome. Thank you so much. So, good afternoon, everyone. Thank you so much for having me here today. Again, my name is Stephanie Ross. I'm one of the psychogeriatric resource consultants with Ontario Shores. So, to get right into it, today's presentation focuses on understanding sexually expressive behaviors in individuals within your care setting. While each situation is unique and can be complex in nature, this session provides a general overview of how to support individuals living with dementia who may display sexually expressive behaviors. The emphasis is on responding with compassion, dignity, and respect while maintaining safe and appropriate care practices. So, in today's session, we will cover understanding intimacy and sexuality, so defining and understanding key concepts, why intimacy and sexuality matter across the lifespan, looking at the emotional, physical, and relational needs, respecting autonomy, preferences, as well as dignity, looking at contributing factors, so looking at cognitive, physical, emotional, as well as social influences, as well as environmental and cultural considerations as well. So then we'll be looking at assessing competency, which we will review how to evaluate an individual's ability to consent and make informed decisions using, the MMSE score, the exploitation risk, nature of the relationship, potential risks and safety concerns through a decision tree. We'll talk a little bit more about that in a bit. But then lastly, we'll look at practical guidance. So kind of the do's and don'ts for supporting intimacy and sexuality for those under your care. Common pitfalls to kind of avoid and how to respond professionally and ethically. So this slide really highlights why intimacy and sexuality are so important, especially for people living with dementia. These are not optional or extra parts of life. They are basic human needs that directly affect well-being, identity, and emotional health. Historically, sexuality in older adults, especially those with dementia, has often been ignored or minimized. But research and clinical experience, tell us something very different. So sexuality and the need for intimacy do not disappear with age or cognitive change. As the quote on the slide reminds us, sexuality is a fundamental part of, being human, and every person, young or old, healthy or ill, remains a sexual being. So this includes people with dementia. So the second quote emphasizes the power of touch. Touch is not just comforting. It's necessary for physical and mental health. When people are deprived of touch, especially through isolation, they can definitely experience anxiety, confusion, hallucinations, and emotional distress. So when we talk about intimacy and sexuality, we're not just talking about sex per se. We're actually talking about the physical closeness, emotional connection, affection, companionship, and feeling valued. So these needs include physical, social, mental components. They are a part of the whole person, part of what makes everyone unique or a specific person unique. So sexual expression is a basic human need, just like food, safety, and connection. So for many older adults, sexuality is not about performance or appearance. It's about affection, loyalty, companionship, and just feeling alive. So it can represent love, warmth, and emotional security. And for people with dementia, one of the greatest losses they experience is often the loss of intimacy. So the loss of being held, touched, loved, or even that emotional connection. The loss can essentially be just as painful as any physical decline. So now I'd like to introduce a case study involving a person who has been described as displaying sexually expressive behaviors. I want to pause here and ask you to think about how language matters. The way we label behavior, whether we call it inappropriate, sexualized, or expressive, already reflects our values, assumptions, and comfort level with sexuality. So before we go any further, I'd like you to take a moment to reflect on this case, to think about, how your own beliefs, your experiences, your culture, and personal values might shape how you interpret what is happening. So as staff and caregivers, we don't come to these situations almost as blank slates. We all bring our own belief systems, comfort levels, and boundaries. So sometimes these do influence whether we see a situation as a risk and or a problem or a basic human need being expressed. So this case study isn't just about one individual, it's also about how we as professionals respond. So the goal is not to judge, but to become more aware of how our reactions can either support or unintentionally harm the person involved. So as we go through this example, I invite you to keep asking yourself, what am I assuming? What am I reacting to? And how can I respond in a respectful and ethical and person-centered way? So the case scenario here is Mr. B has Parkinson's disease. He's on levodopa. He was found walking up to the wheelchair-bound female co-peers in the hallway while holding his penis in his right hand. When he decides to stop in front of them, he is seen shaking his penis and mumbling incoherently. So Mr. B has not exhibited this behavior in the past. So at this time, I'd like if you wouldn't mind taking out your cell phones, if you have your cell phone available, and if you wouldn't mind scanning the barcode that's just on the screen here, or you could go to slido.com and enter in through hashtag ASDR. But I'm not going to spend too much time on this, but essentially, I would really love to know, what are your initial thoughts and emotions kind of pertaining to this particular case scenario of Mr. B? So I'll give everyone just a few minutes if you are able to participate in just a little Slido. I love it. Unmet need. That is perfect. The first one that kind of comes to mind. That's fantastic. Thank you. It does take a little second for all of them to pop up. So the second one here is lonely, right? Might have pain or a UTI, in need of sexual intimacy, missing intimacy, discomfort, disease process. Absolutely. Perfect. I can see some individuals are still typing. I know it takes a few seconds. So he may be feeling unwell, unusual presentation. Does he have to void? Is the shaking his Parkinson's? I love everyone's mindset here with just these thoughts that are kind of first coming to your mind. Love it. Perfect. Wonderful. Thank you all so very much. I know I wasn't going to spend too much time on this particular portion of the presentation, but I really love how everyone's brains are already kind of going to that person-centered focus sort of thing. So, but then I also see here looking for the washroom. How do the women feel, right? So that is also another integral part of it that we're going to chat about in a little bit. I hope I didn't miss any of them here, but perfect. Awesome. Thank you so much for sharing your thoughts on this. I really, really do appreciate it, because it is going to, we're going to chat a little bit more about some of your thoughts, essentially, when we go throughout the rest of this presentation. So thank you so much again for participating in that. So this slide is essentially all about how we interpret what we see. So I loved all of your thoughts and feelings that you were sharing on the previous slide. So essentially, when you look at behaviors, right? Behaviors that look sexual on the surface can often be misunderstood, especially in those living with dementia. So many actions that are labeled as sexual may actually be about something else entirely. The person may be seeking comfort, reassurance, or human connection, but not necessarily that sexual activity. And when it comes to touch, for example, touch is one of the most powerful ways humans communicate safety, familiarity, and belonging. So when someone reaches out, holds a hand, or seeks physical closeness, it may be their way of saying, I feel lonely, or I'm scared, or I want to feel connected to someone. So for someone with dementia, the ability to use words to express these needs are definitely reduced. So instead, the body becomes that language. So what looks inappropriate to us may actually be an attempt to meet a very basic emotional or social need coming from the person themselves. So it's also important to remember that the person may not be thinking about sex at all, and that they may simply be trying to recreate a feeling of closeness or security that they remember from earlier in life. So our role is to pause before we react and ask, what is this person really trying to communicate? When we shift from judgment to curiosity, we are better able to respond in a way that is respectful and supportive. So this slide really highlights some important principles to keep in mind when supporting older adults, including those living with dementia. First, sexuality does not disappear with age, as I mentioned before. So for many people, it remains an important part of their identity, their relationships, and a sense of self throughout their entire life. So maintaining sexuality and intimacy isn't just about pleasure, it's also about health and well-being. That feeling desired or feeling to be connected and emotionally close to someone can reduce loneliness, improve mood, and support, again, overall quality of life. So as healthcare providers and support staff, our attitude does matter. So when we are open, respectful, and non-judgmental, people are much more likely to feel safe talking about their needs, their concerns, and or if they have questions. If a person feels embarrassed or shamed or even dismissed, they're definitely less likely to speak up, and their needs may go unmet or come out in other ways, such as distress or these behaviors that seem very challenging. So our goal is to create an environment where older adults feel heard, respected, and supported in this very personal area of their lives, just as they would be with any other aspect of their care. So, this slide reminds us essentially that sexuality and intimate behavior are not interpreted the same way by everyone. Each of us views these behaviors through the lens of our own beliefs, our own experiences, and our own comfort levels. Religion can definitely play a role. For some people, certain sexual acts or language or expressions are viewed as sinful or morally wrong. So culture also shapes what is considered acceptable, private, or respectful. Family background matters as well. So some caregivers grew up in families where physical affection was very common, while others grew up where, touch was very limited or discouraged. So personal boundaries, comfort with closeness, and ideas about personal space all influence how we react. So this is why one person's behavior might be seen as inappropriate by one staff member and completely normal by another. These conflicting values can lead to inconsistent reporting and inconsistent care. So as professional caregivers, we have a responsibility to recognize when our own emotions or our own discomfort or beliefs are influencing our response. And that awareness always helps us stay fair, respectful, and again, person-centered. So we need to get in touch with our own reactions before we label a behavior. When we don't document or communicate, we should describe what we actually observed, not what we think it meant. So for example, if we chart, what the person did, not whether we think it was sexual or inappropriate. It's also helpful to ask, whose problem is this? Is the behavior distressing the person? Is it harming anyone? Or is it making us uncomfortable? And finally, no matter what the situation is, we should never shame or embarrass or become upset with the person. This is a deeply sensitive area, and how we respond can either protect a person's dignity or, in hindsight, damage it. So these are just some possible medical reasons for someone to have a decline in their sexuality. And these are not limited to, but only what's on the screen here. There's many different reasons as to why someone's sexuality might decline in nature. But to start, we have medications, right? Medications which can cause impotence or increase or decrease, in an individual's libido. There's infections, frontal temporal lobe dementia, which we're going to chat about in a little bit, why that can be the reason for declining in elderly or in sexuality within the elderly. Prostate cancer, surgeries, whether through prostate or uterus, physical barriers. So if someone has catheters or ostomy bags, poor mobility and pain, as well as change of body image and depression. So this slide looks at how dementia can change the way a person experiences and expresses sexuality. So many people with dementia experience a gradual decline in sexual interest or in initiating sexual activity. However, in some cases, the opposite can happen, where people may become more sexually driven or disinhibited. And this is often called, hypersexuality, and it is related to changes in the brain, not to a change in the person's character. So one of the key issues is impulse control, and that's what I was speaking to with regards to frontal temporal lobe dementia. So impulse control, damage to the parts of the brain that help us filter our behavior can make it harder for someone to stop themselves from acting on a thought or a feeling. So that's why someone might say or do something that feels out of character to them. Then we have sequencing problems. So sequencing problems are another factor where some people with dementia experience apraxia, which affects their ability to carry out tasks in the correct order. And this can lead to behaviors that appear confused or awkward or out of context, and that is including in intimate situations as well. So disorientation to person and place can also play a role. A person may not recognize, where they are or who they're with, right? And that's agnosia, right? Another cognitive loss associated with dementia. And this can lead, for a person seeking comfort or closeness in ways that don't fit the exact situation that's kind of happening or the interaction at play. So despite all of these changes, one thing remains constant. People with dementia still need to feel wanted, they still need to feel valued, and they still need to feel connected. So seeking that closeness, that affection, or touch is often a reflection of that very human need that all of us have to have belonging. So this slide here gives us examples of behaviors that may, be seen within your care settings that have a sexual or intimate component and can be challenging to manage. So these behaviors are not happening because the person is trying to be inappropriate or offensive. They are often the result of changes in the brain caused by dementia. So including impaired judgment, reduced impulse control, as we'd mentioned before, and difficulty understanding those social boundaries. So examples include, self-stimulation in public areas, or making verbal or physical sexual advances towards staff or other residents or visitors, etc., within their care setting, and or removing clothing or exposing oneself. So while these behaviors are not acceptable, of course, in a public or shared, care setting, it's important to remember that they are not intentional acts of misconduct. They are the symptoms of the disease. So our job is to keep everyone safe and maintain that dignity, both for the person and for the others within that environment. So that means responding calmly, respectfully, and person-centered. So instead of reacting, which may cause embarrassment or that shame or that feeling of shame, we should think in terms of redirection, right? And privacy and support. So the goal is not to stop the person from having those needs, but to help them express those needs in ways that are safe and appropriate for their setting. So with that kind of being said, this area really focuses on what staff can actively do when responding to unwanted or inappropriate sexual behaviors. So first, it's important to address the behavior calmly, clearly, and respectfully. We should name what is happening and state that it's not acceptable in this environment. However, avoid shaming, but do not ignore it, right? We want to always use the person's preferred name. This helps ground them and reinforces that respectful person-centered care. We want to, remind the person who you are and what your role is, right? And that can reduce confusion and misinterpretation from the person. So saying that I'm your nurse today or I'm your PSW, I'm here to help you with your care, it helps sets those boundaries. So being mindful of your own touch as well. So touch is touch that is appropriate in care, of course, like assisting with hygiene care or offering that reassurance, should be clearly purposeful and professional, right? So when possible, supporting autonomy. Another example could be allowing someone to wash their own genitals, right? So this maintains, again, that dignity and reduces the risk of misinterpretation or distress from the person. And finally, when appropriate, providing a same-sex care provider can help reduce discomfort or boundary confusion for some individuals. So these strategies protect the person's dignity while also protecting staff and maintaining those safe boundaries. So this slide focuses on what we should try to avoid when responding to sexual or intimate behaviors in people living with dementia. So first, try not to appear shocked or angry or embarrassed. Even when a behavior feels uncomfortable, reacting strongly can escalate distress, fear, or even confusion for the person. So in Mr. B's case, it's especially important to not overreact because what we see as inappropriate, again, may have a completely different meaning to him based on his cognitive changes, his emotional needs, or his misinterpretation of the situation. So some of these, don'ts apply more to people whose behaviors are intentional or more persistent, which is why assessing capacity and competency is so important. So we should avoid using language that could be interpreted as maybe flirtatious or suggestive or intimate. For example, saying like, honey, it's time for our bath. It might send some mixed messages and can unintentionally reinforce that sexualized behavior. So the other thing is do not encourage inappropriate jokes or comments by laughing or kind of replying or engaging with them, even if the person seems harmless or humorous, because again, almost that response can be misinterpreted as permission, right? Or it's taken as permission. And then finally, never respond to unwanted sexual behavior with that positive reinforcement, such as attention or even joking or affection, because this can again unintentionally strengthen the behavior. So the goal is always, again, to maintain safety, dignity, and clear professional boundaries while still being compassionate. So this slide here reminds us of what looks like sexual behavior is often influenced by many underlying factors. So especially medical and neurological changes, damage to the frontal lobe can reduce a person's ability to filter their actions. So this can lead to disinhibition, where people say or do things they would normally keep private. So people with dementia can also misinterpret their environment or the people around them. They may confuse a caregiver for a spouse or misread touch or tone of voice as something more intimate. So boredom and lack of stimulation can also play a role where someone has nothing to engage them, right? So they may seek out sensation or connection in whatever way they can, right? They can become more curious and an unstimulated brain stimulates itself for those folks that have taken dementiability, right? Where that purposeful engagement can really combat kind of that boredom that might be at play that could potentially be that contributing factor. So sometimes, what looks like sexual behavior is really, again, just physical discomfort, right? Clothing that feels too tight or maybe irritating or itchy, or there's pain or there is a urinary tract infection, which can lead to someone to touch or rub their genital area. If you even think of yeast infections, right? Yeast infections, if an individual has a yeast infection, it could be misinterpreted as sexual expressive behavior, right? So just different context, but again, just what we're observing from the person. So accidental exposure can happen simply because someone forgets where they are or becomes confused while getting dressed or undressed, right? So maybe they were trying to get to the bathroom. They thought they were in the bathroom. However, they were just outside of it. So then that's when they started to disrobe and things to that effect, which again, if the staff is walking by, they could misinterpret that as sexually expressive behavior when really it's, again, just that accidental exposure may be due to agnosia, right? That loss of recognition of where they are or that they just didn't quite make it to the bathroom. So, and sometimes, a person is simply looking for comfort. So wanting to snuggle or climb into bed with someone may be about feeling safe and cared for. And again, just not about a sexual intent or the sexual nature per se. So when we think back to the case of Mr. B, these factors are especially important as many of you had kind of attributed within that little Slido poll. His Parkinson's disease and his tremors could easily be mistaken as as intentional when they are not, right? Those are the movements that come with the disease process with Parkinson's, and without looking at the medical context, his behavior could very easily be misunderstood. So the key takeaway here is this, that before labeling a behavior as sexual or inappropriate, we must look for the medical, physical, and emotional and environmental causes. And just to kind of keep in mind that if we say that a person with dementia is inappropriate in nature, we're now implying that this person with dementia knows the difference between right and wrong, when in fact they do not know the difference between right and wrong. So again, we just really have to be objective in what we're seeing when it comes to those that are in our care. So when it comes to situations, that may be a bit more complex or sensitive or controversial, it's important not to handle them alone. If you do have access to an ethicist or an ethics committee, they should be involved to help guide those difficult decisions. These situations can often affect not just the person, but their families as well, but also members of the care team too. So having that open, respectful discussion, with everyone involved is essential. And it's an integral part of caring for the person. So at the same time, it's important to remember that a family's values may not always match the individual's wishes or their history as well. So that's something to really keep in mind too. So one of the most helpful things we can do is learn about the person's past, talking about the person and their family, about previous relationships, previous beliefs they had, the patterns of their intimacy, right? So these are all things that help us understand what feels normal and meaningful for them. So if possible, we can ask about those past partners, those marriages or long-term relationships, because this will give us context to what we're seeing now. Because typically the average person with dementia, they're going back into their long-term memory bank, right? So they might even have feelings or thoughts about a partner previous to the spouse that they have right at the moment, right? So that's why it's so important to try to capture as much of their past as we can, because that really does give us the context as to what we might be seeing now with the clinical presentation of the person. So it's also important to assess whether the person still recognizes their spouse or partner on that fact. So, whether they may be confusing others for someone from their past, just as I was mentioning, that can have a very big impact on consent and safety. And lastly, or finally, consistency is key. So organizations need to have those clear policies and procedures, put into place that guide how these situations are handled. So those policies should protect the individual's rights while also safeguarding people who are vulnerable or unable to object to that unwanted attention. So the goal here, of course, is to balance dignity, autonomy, and safety for everyone that's involved. So this slide here brings us back to a problem-solving mindset. So instead of reacting emotionally or automatically labeling that behavior, we can pause and ask some of these important questions. So first, again, who is actually being affected? Is this behavior upsetting or unsafe for the person? Is it affecting other residents or other individuals within their care environment, or staff or family members? Or is it mainly creating discomfort for those who are witnessing it? So next, we ask whether the behavior is truly sexually motivated. Could it be about comfort? Could it be about confusion? Is there loneliness at play here? Is there pain at play? Is there boredom? Or is there a need for reassurance? So we also want to consider whether this is normal for the individual. Is this consistent with their personality or their past behavior or their life history? Or is this something that is new that may signal a change in their condition or their environment? So triggers are another key piece, right? So does this happen at a certain time of day, right? During personal care, when the person is tired or anxious or overstimulated, identifying these patterns helps us prevent these problems before they even escalate. And I wouldn't be a PRC if I didn't mention the BSO-DOS. The BSO-DOS is one of those evidence-based tools that you can utilize in healthcare to identify those patterns and trends and to see where those triggers might be within a person's day or who the triggers might be within the person's day. And finally, again, as a core competency or Sarah had mentioned, we can also use the pieces framework to help guide our thinking, right? So that does take a deeper dive into looking at the physical components of the person, the intellectual components, the emotional factors that might be at play, looking into their capabilities, right? What are they capable of? What are unused? Everything to that effect, and as well as their environment and social factors. So again, this is to understand what is driving the behavior. And the pieces framework can kind of help solidify, what we're seeing in the person, and therefore come up with a plan to help eliminate that behavior, or to at least have the person express it in more of that safe, dignified way. So when we use, this kind of structured approach, we move away from the blame and kind of toward that understanding. And that leads us to better, safer, and more respectful care, kind of in hindsight. So when we're looking at this slide here, I'm going to introduce kind of a structured way to think about whether someone with dementia can consent to an intimate relationship. So while we are not using this decision tree for our case scenario today, Mr. B, it can be very helpful in other situations. So especially, when two residents want to form or continue a relationship. This is not meant to replace your organization's policies and procedures. It's essentially that guideline to help support good clinical and ethical judgment. So these decisions, should always involve the entire interdisciplinary team, and when appropriate, of course, the person's family. And as I had mentioned before, if you do have access to ethics, that is also someone that you can get involved to help with this decision making. So the first step comes from Lichtenberg's work, and it looks at cognitive status using the mini mental state exam. So according to the study, if the person scores above the 14, they may be able to take part in an assessment interview. If the person scored below 14, the person is generally considered unable to give informed consent. Now, again, this is just that guideline, because there are so many other factors when it comes into play for deciding if a person is, competent to participate in this said relationship. So it's not just this like decision tree that you would be focusing on. There's so many other things that are at play here. So I just wanted to keep that in mind as we continue. So the second step looks at exploitation. So we ask whether the behavior is consistent with the person's lifelong values and beliefs. And we also ask, whether the person can say no to an unwanted contact. And if they can't protect themselves from being taken advantage of, they can't consent. So essentially, if that person is unable to verbalize no, or to essentially guide the person away, right? Or to gesture with something that they're not wanting, that unwanted behavior there. So the third step here focuses on awareness of the relationship. And this is also a really integral part too, right? Where we need, does the person know who the other person is? Do they understand, whether this person is really their spouse, or is it just someone that they're confusing with maybe a past partner, right? So, and also, can they describe what kind of intimacy they're comfortable with? And if they can't, they're not able to consent kind of at that time. So when it comes to the final step here, this looks at awareness of the risk. So does the person understand that the relationship might be temporary? Can they explain how they would cope if the relationship ended, right? So let's just say if the person was moved to a different home care area, how would it affect that person? Would it be so unbelievably distressing to them if they lost them, right? And gosh forbid if something happened to them where they had passed away, right? These are things that also need to be taken into account as well. So if they answer yes to these questions, they may be considered competent to participate in that relationship. But if not, we still provide that support, but we also put up safeguards in place, such as reminders, and supervision to protect them from that harm. So the goal of this process, again, is to not deny people the connection. It's to balance the dignity, autonomy, and safety in a fair and thoughtful way. So no matter what setting we work in, whether it's long-term care, acute care, or the community, the question is, what is the realistic goal for managing sexual and intimate expressions within your care setting? We can't ignore these needs, but we also can't allow situations that put people at risk. So our overall goal is to find that balance. On one side, we recognize that sexual expression and the need for intimacy are normal parts of being human, even for people living with dementia. But on the other side, we have the responsibility to protect everyone. So the person themselves, the other residents that are within the home, or the other individuals that are living within the person's home, staff, visitors, all of those individuals from harm or distress or that unwanted contact. So this means that we aim to support dignity and personal rights while also maintaining safety, boundaries, and respect for others. So there isn't a one size fits all answer. And that's also kind of what we were saying with the decision tree, right? It's not a one size fits all. There's not, one specific case that's going to suit everyone's needs. Essentially here, where every situation requires thoughtful consideration of the person, the environment, and the people around them. So I encourage you to reflect on how this balance looks in your own workplace or your own care setting, and how your team can work together to support both that autonomy and safety of those that are in your care and those that are involved with the person that are in your care. So when it comes to, I hope this slide kind of brings everything together, where into a practical approach for managing sexual expressive or intimate behaviors in your care settings. So first, again, we should focus on the non-pharmacological strategies. These are always the starting point and should be tailored to the individual. Medication is not the first solution. We need to have that understanding and support come first. So we begin clearly by defining, the target behavior, what exactly is happening, when and where and with whom. Being specific helps the team respond consistently. So next, we want to look at what has already been tried, which approaches have already worked, which didn't work, and why, right? And make sure we care plan it, making sure that we put that communication out there so that everyone is kind of on the same page, right? That kind of coincides with that consistency I've been speaking about. So with that being said, this helps us build on, what is effective rather than repeating what isn't, right? We don't want somebody to trial something that they know or that they're unaware of has already been trialed and it's not going to work this time, right? Because we all know how precious everyone's time is in their care settings. And I always say this in every single education I do, there are never enough hours in a day. And so if we know that something doesn't work, let's communicate that to the rest of our staff and our team so that we're not all starting, from square one. So we also identify what protective measures are needed. And that could be, to the extremes of maybe even putting the person on that one-to-one kind of observation from that safety perspective. But that also could mean that maybe we need to look at environmental changes or clearer boundaries to kind of keep everyone safe. So those are things to kind of keep in mind. And then we need to decide what further information or investigations are required and who is responsible for kind of following up on that. So that might include, nursing staff, allied health professionals, physicians, psychiatrists, social work, even family can be involved in that process. So medical issues should always be ruled out first. Of course, we have delirium, infections, pain, or skin irritation that can all drive the behaviors that look sexual. So we also can review cognitive and sensory factors. Is the person confused? Are they overstimulated? Or are they unable to interpret what's going on around them? The environment, matters too. So that noise, the lack of privacy, boredom, or even those crowded spaces can all trigger or even worsen behaviors. And I'm sure most of us within this virtual room have kind of seen those firsthand. So finally, education, education and support for caregivers and staff is essential, right? And it's when people understand what is happening and why, they feel more confident and therefore respond in a calmer and more respectful way. So the goal is not just to manage the behavior, but to support the person's dignity, safety, and therefore quality of life. So as I had mentioned earlier, it's critical to remember that many of these behaviors, again, are not sexual in intent, but rather reflect a very strong need for intimacy or comfort or reassurance or just that of human connection. And I know many of us that probably worked within the pandemic probably saw what that loss of touch did to a lot of those that are in our care. I know, like working on the floor during the pandemic, when there was that social isolation, not having that contact with those spouses that they did remember and, they really looked forward to seeing every day, definitely took a toll on them, right? So that's why our approach must always be very individualized, taking into account the person's physical abilities, their cognitive level of functioning, their personal history, of course, and most importantly, their likes and dislikes. So for some individuals, meaningful engagement can significantly reduce these behaviors. And that's what we talk about, that purposeful engagement, those non-pharmacological interventions. Many of these, I can list a few here, but definitely not limited to, but like pet therapy, there's doll therapy, there's art activities, there's poetry, there's the hugging sloths or like the hugging animals, right? The weighted animals that definitely can help with that touch factor, of course, right? Music brings everything out within a person, I feel, and it definitely has a person reminisce even about times, that they did have those feelings of intimacy for someone that might not be there anymore. But you can even think of coloring, right? Or various other forms of creative expression that can provide that comfort and connection, right? Whether they're activities that you're done individually or whether they're activities that can be done as a group, right? Where you do have that emotional connection sometimes to those that are participating within the same group. So in situations where misidentification is occurring, for example, the person believes a staff member is that spouse or a familiar figure, a change in environment can be helpful. And that sometimes is, what is necessary in the case, right? You might need to move the person from that environment. That person, they might need to go to a different floor, a different care team, because maybe that one staff reminds them of the person. And I'm just going to an extreme example here of maybe who their loved one had or spouse had an affair on, right? Where that emotional memory is going to stay a lot longer than those long-term memories, right? And we talk about this in GPA and everything as well, where that emotional memory stays a lot longer, where individuals might just have to be removed from that specific area in order to help help in a dignified, respectful way to continue care for that person. So it's also important, again, to respect the person's privacy and dignity at all times. Privacy can reduce that embarrassment, agitation, and escalation of behaviors. And again, just kind of going to extremes, right? If we know the psychosocial history of a person where maybe there was sexual abuse or sexual assault at play too, right? Those are very sensitive areas in which, these factors can all kind of come to play where you're seeing some of these sexually expressive behaviors and or responses to personal hygiene care for that matter.
Stephanie.
So, oh,
Oh,
sorry.
sorry to interrupt. I apologize for
Yes,
the late heads up. You got about 2 minutes left.
perfect. I'm almost finished. Wonderful. So we should always consider, whether the physical discomfort is contributing to that behavior. Again, if they're too hot, do they need to use the washroom? Are they experiencing irritation, itchiness, again, that pain, or if there's another unmet physical need? And then finally, we need to look closely at the environment itself. So that noise, that overstimulation, maybe lack of structure, or the unfamiliar surroundings can all play a role in triggering or maintaining these behaviors. So by addressing these factors, we shift, our focus from simply managing behavior to truly understanding and meeting the person's underlying needs. So with that being said, I really do want to thank everyone for taking the time to listen to my presentation today. I really appreciate your attention and your engagement, and I'd be happy to answer any questions that you might have at this time. Or I also have my contact information there as well.
Perfect. Thank you, Stephanie. We do have actually a really great question in the chat. It says, can you talk about if two dementia residents expressing sexuality towards one another with both consenting at this time, what happens if something changes and someone gets hurt? Should it have been stopped?
So, and that's again where it's not one size fits all for each person. I think each interaction, I mean, as dementia cases primarily progress, right? In the sense where cognition might decline, I would almost suggest, and again, this is something that should be talked about amongst the entire team, but reevaluating kind of that consent, like reevaluating where the person is at, where the partner is at, because yes, things can change, right? And again, you're looking at so many different factors from that piece's perspective, right? You're looking at the physical components of things, the intellectual. Is that causing the person more distress now when before it wasn't? right? And things to that effect. So, and of course, if it's a safety concern as well, right? I think always when it comes to those particular situations, we can always revisit and reevaluate and determine safety and risk, and distress, I think, amongst the individuals. I hope that kind of answers your question, because I think it's kind of an ongoing kind of assessment practice that we would probably have to put into play, especially when there are two individuals that find love again once they get into long-term care. Maybe they do have spouses that have passed and they've found this like lovely connection where, whether it's intimate or not, right, it's not necessarily always intimate, but that's where we just need to assess the safety and risk, I think, ongoing, and depending on how often it is would depend, I think, on each individual per se. Yes, I hope that answers it.
Thank you so much, Stephanie. It looks like that was the only question we had in the chat, which
Okay.
is perfect timing because we are going to be
Well,
jumping into our second break for the afternoon. So once again, huge thank you, Stephanie, for the wonderful
very
presentation.